Evolution of distal radial fracture treatment. We are going to cover history, aims of treatment, and changes in treatment methods. We all know the quote from Abraham Colles that the limb will at some remote period enjoy perfect freedom in all its motions and will be completely exempt from pain. The deformity, however, will remain undiminished throughout life. But what was the life expectancy in 1814? I think you're going to be surprised. Gentry and professional persons, 35 years. Tradesmen and their families, 22 years. Labourers, mechanics and servants, 15 years. So Abraham Colles didn't treat many old people. Looking at the anatomy of the distal radius, it has two fossae, a scaphoid fossa and a lunate fossa. There are some weak, somewhat puny ligaments at the back of the wrist on the dorsum, and then some really strong volar ligaments. And those really strong volar ligaments are attached to the scaphoid fossa of the radius and not to the lunate fossa. And the lunate fossa has no ligamentous attachment, so ligamentaxis will not reduce any aspect of the lunate side of the radius. Wrist fractures are really common, and they're commoner in ladies than they are in gentlemen, and there's a risk of 15% in females and 2% in males of developing a fracture throughout their lifetime. There are two peaks of incidence. One young patients with high energy and good bone, and one peak in later on in life where the bone is not good and they're low energy injuries. The principles of treatment of distal radius fractures are the same for principles of treatment of any fracture. You reduce it, you hold it, and you rehabilitate it. Now, as far as evolution of fracture treatment is concerned, we are going to concentrate on the holding of these fractures. How do we reduce it? Well, we reduce it the way that Charnley described in his book, Close Treatment of Common Fractures. We perform traction, we increase the deformity, and then we use the periosteal sleeve to reduce the fracture and back down to its original position. And then we hold it in some form of plaster, and this is what we used to use for almost all distal radius fracture treatments, perhaps in the 1960s. But we've all seen a case like this of day one, an intra-articular fracture which is displaced. It gets reduced, and 1 week it starts to slip, and at 5 weeks it's slipped back. And if you look at the day one picture and the 5-week fracture, they're almost exactly the same. So casting maintains a reduction in only 33% of cases, and in 80% of cases there's a severe loss of fracture reduction. But the reduction, the functional outcome is not terrible. The dorsiflexion of the wrist here is 40 degrees, and that's a good functional range of movement, and she's happy. That's what Colles predicted. We then started to use K-wires in the 1980s, and this configuration of K-wires illustrated here is probably the most stable one. 2 K-wires in the radial styloid, one going dorsally and one going volarly, and one on the ulnar-most aspect of the dorsal aspect of the radius going volarly. But K-wires penetrate, incinerate, irritate, and suppurate. So we then move on to external fixation in the 1980s. We tended to use this as a neutralization device to other forms of fixation, such as K-wires or perhaps cement, because the fracture reduction got lost with just an external fixator. How do X-Fix compare with K-wires? Well, there's no difference in grip, motion or satisfaction, but the X-Fix does give a bit of a better reduction, but it gets more pin track infection. We then thought of trying to get an anatomical reduction to try and prevent something that Abraham Colles mentioned in his thesis that isn't commonly known. He was referring to malreduction. And he said, when referring to malreduction, the patient is doomed to endure for many months considerable lameness and stiffness of the limb, accompanied by severe pains on attempting to bend the hand and fingers. So we then looked at trying to get more anatomical reductions, and dorsal plating came on in the 1990s. And this was the pie plate, which was difficult to put in, very difficult to take out, and it seemed to cause quite a lot of dorsal wrist pain and stiffness. But there were 3 randomized trials comparing dorsal plating versus X-fix. And the range of movement was in fact equivalent. There was a weaker grip for it following internal fixation, but there was also tendinitis and infection, and both these were causing similar problems. So then moved on in 2000 to volar plating, where we were putting a plate on the volar side of the wrist. And this is a fracture of the distal radius. You also see there's a scaphoid fracture here, and it was fixed with a 2-column variable angle plate and a scaphoid headless compression screw. The advantage about the volar plate was the indirect reduction technique. You can put this plate on the distal aspect of the radius when it's displaced, and thus the proximal arm of the plate lies off the shaft of the radius. Once the distal aspect's fixed, then you can actually get the shaft of the plate onto the shaft of the radius, and that will reduce the fracture indirectly. I'd like to introduce something to you called Scott's parabola, which is the fall and rise of a new surgical technique. Now, Scott was an obs and gynae fellow, and he started off with, he said there was a promising idea. It then became a possible value as a research tool. You then saw encouraging reports, widespread enthusiasm, media pressure, general introduction, and it became a standard treatment. And then what happened is that doubts crept in. There was a damaging survey, a widely publicized medical legal case, and then it became condemned. And then there were operating staff ponder uses for large quantities of expensive, obsolete equipment, and something that I really appreciate is ancient surgeons amaze their juniors with rollicking stories of the old days. Look at the shape of that graph. For external fixation, same graph shape. Became fashionable, then didn't become fashionable. Dorsal plating, same shape. And then we see volar plating, and it's on the up at the moment with 26 different types of volar plate in 2004, 34 in 2007. There are now 75 different types of volar locking plate. This is huge money. And I think that the upward trend of volar plating is going to just start going down. So I think we're going to see the red dots illustrated here because of 3 studies. One from Innsbruck in 2011, one from Nottingham in 2013, and a really good study, multi-center study in 2013 from Coventry by Matt Costa, which essentially says that K-wires and volar plates are exactly the same as far as functional outcome. There is no difference at all. So radius fracture treatment, there is no one answer. Abraham Colles had no gentleman over 80. He had no 80-year-old ladies playing golf. He had no barristers or lawsuits. And there was no internet or access to internet wherever you wanted it. So in summary, reduce the fracture, hold it by whatever means you know best and does best in your hands, and then rehabilitate it. Thank you.